Okay, Dr. McBride, take it away.
Welcome, everyone. I am honored to introduce today's first grand round speaker, Dr. Nikolaos Spilias. Dr. Spilias is an interventional and structural cardiologist and assistant professor at the University of Miami Miller School of Medicine. Dr. Spilias earned his medical degree with honors from the University of Athens School of Medicine in Greece. After moving to the United States, he completed his internal medicine residency at Emory University School of Medicine and pursued a fellowship in cardiovascular diseases and an advanced fellowship in interventional and structural cardiology at the Cleveland Clinic. Dr. Spilias has numerous publications in peer-reviewed journals and presentations at national and international conferences. In 2021, he received an award from the American College of Cardiology for his research project on 3D printing for patients with complex tricuspid valve disease. It is my distinct pleasure to welcome Dr. Spilias to the Department of Medicine Grand Rounds to discuss the management of patients with chronic stable chest pain.
Thank you very much for the introduction, and thank you very much for having me today present at the Medicine Grand Rounds. I'm very excited to do so. I will move forward with the talk. So I would like to talk to you about a very practical subject. Can you hear me well, first of all, just to make sure? You can hear me well, perfect.
Yes, we can hear.
Okay, perfect. So I would like to talk to you about a very, very practical subject, about something that you see or probably on a daily basis, patients with stable chest pain or chest discomfort. And I would like to describe the contemporary approach to this based on the most recently published guidelines. I have no disclosures. So these are the objectives of my talk. I would like to present the contemporary approach to the risk stratification and diagnostic workup of stable chest pain, review the clinical decision pathway for stable chest pain based on the guidelines. And I would like also to describe and present to you new tools we have to diagnose CAD. And actually, this is one of the technologies, the new technologies that we have here at the University of Miami Hospital, and we're the only hospital in Miami-Dade County to offer that. And this is the CT-FFR. I'm going to talk about it more later. So these were the guidelines published at the end of 2021, about 2 years ago. And this is a nice acronym. Chest pains from the guidelines. It's as we know, the chest pain is the second most common cause for ER visits in the US. There are about like 6.5 million ER visits for chest pain every year. And it's worth to note that more than 50% of patients who present for chest pain have non-cardiac chest pain, meaning that we need to really be very careful and improve the ways we assess, these patients and make sure we rule out that they have cardiac chest pain. So I'm sure you're very familiar with the characters of the pain, and obviously history is the most important in these cases. There's this spectrum here based on how the patient describes the pain, starting from central pressure squeezing, going all the way to sharp, shifting pruritic positional, lasting a few seconds. And based on the new guidelines, we kind of eliminated the term atypical because it doesn't really provide, it's not really the best way to characterize the pain as atypical and atypical. And we like to describe the chest pain as cardiac, possibly cardiac or non-cardiac based on the characters. Also, the term chest discomfort is probably preferred over chest pain because sometimes, and many patients don't actually feel pain, but they feel more like something like pressure or heaviness or tightness, which is not described as pain per se. So that's something to keep in mind. So here's the nice pyramid based on the risk of the presentation of the patient. And we're going to focus obviously on stable chest pain, which is mainly an outpatient evaluation. And I would like to just show you quick question you may encounter in the boards. We have a 58-year-old male presenting in the outpatient clinic with chest discomfort while lifting weights, history of hypertension, hyperlipidemia, CKD stage 3B, obesity, mild COPD, prior smoking. He had some knee osteoarthritis, so his activity level is quite limited. EKG shows some left ventricular hypertrophy with repolarization abnormality. So which test would you most likely choose for this patient? So I'm not going to give you the answer right now, but we're going to talk about how we assess this patient. So these are the main questions that we need to ask ourselves. So first of all, what is the pretest probability that our patient has significant CAD? The second question is, based on the risk assessment we do, is should we proceed with further testing? And if the answer is yes, then we need to ask our question, the next question, which is the patient able to exercise? And the last question, which is very important here, is should we proceed with an anatomic or functional test? So this is a very nice table based on the articles from Winter and Suarez Orozco. Was published a few years ago, showing the estimated pretest probability based of having significant CAD based on the age and the gender of the person. And you can see here with the light green color, the low pretest probability, less than 15%. The dark green is the intermediate probability, and this is the category that we need to do further testing. And obviously, this is high pretest probability category for men older than 70 presenting with chest pain. Now, nowadays, we have the coronary artery calcium score, which is a very useful also risk assessment tool. If the score is more than 100, that places the patient in more like in the intermediate risk category. And if it's more than 1,000, obviously in the high pretest probability category. So coronary artery calcium is a very, very useful adjunctive tool to add to the risk probability assessment. So this now busy algorithm and diagram is from the guidelines, and this is what we call the clinical decision pathway to assess patients with stable chest pain. We're gonna focus on the low, intermediate, and high risk categories here based on the assessment I just showed you. So the first category is the low risk category. A patient like younger with let's say like possibly non-cardiac chest pain that doesn't, based on the history, doesn't fit the criteria I showed you earlier for what we call we used to call the typical angina. It's quite easy. If we think that the patient is very low risk, very low pretest probability, no testing is recommended. Now, in patients who have significant risk factors, we can consider a coronary artery calcium score for further assessment or an exercise ECG test. Then we're gonna move to the intermediate or high risk category. For these patients, you have two options, actually, according to the new guidelines. The one option is to follow what we call now the anatomic pathway with a coronary CTA that requires contrast, or do the functional pathway, which is the more like traditional, let's say, pathway of like stress testing, including a stress MRI, a PET, stress and SPECT. Both tests are nuclear, PET and SPECT, or do a stress echo. Exercise ECG is a class 2A indication because it doesn't really like provide like imaging or functional evidence of the myocardium. So we have these two options. So the question is, how do we pick between these two? Because they're recommended equally. So focusing on the functional pathway first, these are our options: so stress MRI, PET, SPECT, and echo. Now, if there is mild ischemia, conveying a very, very low risk situation, we optimize the medical therapy. We focus on prevention. We focus on the risk factors, and we may consider coronary artery calcium score as well for further risk assessment. If the stress testing shows moderate to severe ischemia, again, the first recommendation is to optimize the medical therapy and focus on risk factors. And this is based on the ischemia trial that was published a few years ago that showed that medical therapy has, let's say, very, very similar outcomes with the invasive approach with a cardiac catheterization and stenting for patients with stable chest pain symptoms who have moderate to severe ischemia on stress testing. So this is based on the ischemia trial. The ischemia trial itself had its limitations, but that was, it was adopted in the guidelines. So if the patient has persistent symptoms despite the medical therapy, then an invasive coronary angiogram, so heart catheterization, or a coronary CTA are recommended to get some anatomic information. So now we're moving to the anatomic pathway. And this is essentially the coronary CTA pathway. I would like to focus on this FFRCT technology, which, as I said, it's a relatively new technology. We have it here at University of Miami Hospital, and we're the only hospital in Miami-Dade County that we offer that. So if the coronary CTA shows no significant CAD, no significant stenosis, so then, no further invasive assessment is necessary. We focus on medical therapy and prevention. Now, if the coronary CTA shows high-risk stenosis, severe stenosis, then with severe symptoms, then we move to invasive coronary angiography. But what if the coronary CTA shows what we call more like intermediate stenosis, like 40 to 90%, or even like what we call non-obstructive CAD. So then the recommendation is to proceed with FFRCT. FFR stands for fractional flow reserve, which I'm gonna explain shortly where it came from, or proceed with stress testing to assess for the ischemia burden. And this is the magic number we need to remember. If the FFR CT is equal or less than 0.8, or there is moderate or severe ischemia on the stress testing, then we need to proceed with coronary angiogram for a more definitive assessment. So these are a few, let's say, pros and cons of the anatomic versus the functional pathway. As we discussed, the coronary CTA gives anatomic information, gives information about the severity of calcification, and it's very useful for the interventional cardiologists for planning of the PCI. Up until recently, we could not get information about ischemia with the coronary CTA. However, now with this FFR CT, we get physiologic information about ischemia as well. So these are the different stress modalities: ECG, echo, nuclear SPECT, nuclear PET, and MRI. Obviously, if the patient is able to exercise, we prefer always the exercise stress test over the pharmacologic stress test, because it provides also useful information about the functional capacity. And I would like to talk to you about the concept of fractional flow reserve. So this is part of an invasive assessment, what I'm showing you here right now. So if a patient has what I call intermediate stenosis on coronary angiogram, intermediate meaning 40 to 70%, then what we do is we engage the coronary artery with a catheter, and then we use a very special pressure wire that we advance across the stenotic lesion of the coronary. And technically, we measure the pressure distal to the plaque, to the narrowed part, and the measure in the very proximal, usually left main, which represents the aortic pressure. So FFR is technically the ratio between the distal coronary pressure over the proximal coronary pressure, which represents the aortic pressure. In order to assess the FFR, sorry about that, we give adenosine to induce hyperemia. So it's like performing a pharmacologic stress test during an invasive coronary angiogram. And in the areas of the heart that, for example, supplied by this artery, because of the stenosis, the distal coronary arterial bed is maximally vasodilated already. So usually we don't get more vasodilation, but we may get what we call the coronary steal when we vasodilate other healthy areas of the coronary tree. So this is an example of a very positive, what we call positive FFR, less than 0.8, 0.68. And you can see with red the aortic pressure waveform, which is the proximal coronary pressure waveform. And with green, you can see the distal coronary pressure waveform. And you can see the difference, how lower the distal coronary pressure waveform is. And this is considered a positive FFR, meaning hemodynamically significant stenosis. So it's been shown that patients who have an FFR of equal or less than 0.8, they compared actually PCI versus medical therapy for these patients. And the clinical trials showed that the PCI was associated with decreased rates of urgent revascularization compared to medical therapy alone. So this is why it's part of the guidelines now that if the FFR is less than 0.8 for patients with stable chest pain, that PCI is superior to medical therapy, mainly because of the need of urgent revascularization with medical therapy. So this is sort of like the cutoff that has been validated that the PCI has superior outcomes to medical therapy. This is an example of a coronary CTA with the FFR evaluation. So now what I showed you earlier, during an invasive angiogram with a catheter and a wire, we can do it just from the CTA based on the AI algorithms. So you can see here on the CTA, the LAD has stenosis here and then calcification. And based on the FFR assessment, that's the coronary tree, how it appears with this CT software. You can see that the FFR in the distal LAD is significant. It's significantly low, 0.76, indicating that if we fix the lesion proximally, the FFR is expected to normalize. So if this patient has symptoms attributed to coronary artery disease, has an indication for PCI, if they're not obviously, diabetic and they don't have, an indication for CABG. And based on the assessment of the other coronary arteries, that there's no significant disease, in the circumflex or the RCA. As you can see, the FFR is 0.87, here it's 0.88. If the patient is not diabetic, then does not have contraindications to PCI, then PCI is indicated. An important thing we need to note here is that in order to get a good quality diagnostic coronary CTA, the heart rate needs to be ideally 60 or less. We have a special protocol in place for that with metoprolol plus ivabradine, depending on the patient's baseline heart rate. We have this protocol that we use to optimize the heart rate so we can get the best quality images possible. So, and this is now a study that was published in 2019 that essentially compared the CT FFR with other stress modalities for the detection of hemodynamically significant coronary artery disease. They compared with the gold standard, which is the invasive angiography and the invasive FFR. And this study showed that the CT FFR actually was the most accurate for the detection of ischemia, with the PET in the second place. SPECT, as you can see, is much lower. So PET is usually better quality than the SPECT and fewer artifacts. That's something to keep in mind. So the FFR CT was the most accurate, as you can see here on the ROC curves, for the detection of hemodynamically significant CAD, followed by PET stress. Obviously, every time we assess a patient with chest pain or chest discomfort, we need to keep in mind that there are other causes like non-cardiac cause of chest pain, from the respiratory system, from the GI system. Very often we see patients with chest wall, musculoskeletal pain, and as a diagnosis of exclusion, obviously, psychogenic chest discomfort is in the differential. So I would like to go back real quick to the first question to show you the question again. So this patient has multiple risk factors. They have chest discomfort with exertion. Is a 58-year-old male, so based on the risk assessment we talked about, he's at least intermediate risk probability for significant CAD. The problem is that he has knee osteoarthritis and also some EKG, baseline EKG changes that would probably preclude the performance of the exercise ECG test. So in this patient, in order to assess further based on the guidelines, we could proceed with either pharmacologic nuclear stress test or the coronary CTA as the first test. Now, the coronary CTA with the CKD stage 3B, we need to be careful with contrast, but we have appropriate hydration protocols for that. But in this case, probably starting with a pharmacologic nuclear stress test may be more appropriate. And depending on the degree or severity of ischemia, we can assess this patient further. So for this question, let's say the preferred answer is probably C. So I'm going to move to the end of my presentation. Perfect. So, and this is now another last question I would like to show you. This is now a 75-year-old male who is sent to us for preoperative cardiac risk assessment prior to colectomy for colon cancer. He has risk factors including hypertension, diabetes, has mild dyspnea on exertion after climbing 2 flights of stairs. He had an exercise stress echo already that showed normal LV function at baseline, no significant symptoms, but had this mild 1 millimeter ST segment depression at peak stress and very mild inferior wall motion abnormality on echo. So if you see this patient, what would you do next? They're supposed to have a colectomy. Again, mild inferior wall motion abnormality, not very symptomatic, normal LV function, very like subtle EKG changes. Anybody from the audience can try to, answer this question. Do we need further testing? Is the testing we have enough to proceed with the colectomy? Or we need further assessment with a CTA or cath? I can, yeah, please.
The cardiac catheterization.
Yeah, so this patient, not very symptomatic. The stress echo shows low risk findings, which is a mild inferior wall motion abnormality, which is most of the times the RCA territory. So the key here, I think, is mild, and it's only 1 millimeter ST segment depression, and the patient is not very symptomatic, and they have normal LV function. So actually, this is the sort of like the low risk category after the stress testing. So the correct answer here is proceed with surgery without further testing, because the patient belongs to the more like the low risk category based on the stress testing, for which medical therapy is recommended overall, and focusing on risk factor modification. So these are some of the take-home messages. According to the new guidelines, we should classify the chest pain as cardiac, possibly cardiac, non-cardiac. Again, as a reminder, the term atypical has been eliminated because it doesn't really describe well what's going on. We need to try to use more the clinical decision pathways to minimize unnecessary testing, and it's a more efficient way to evaluate patients with chest pain. We need to always perform a very structured risk assessment to identify patients who would benefit from further testing. Always, it's not always necessary to proceed with further testing if, based on our assessment, we think that the patient has low pre-test probability or the initial test we order shows low risk findings. We should utilize more the new validated technologies like the CT FFR I showed you earlier. And obviously, we always should, have a shared decision-making with the patient about, what test to perform next, and, what are the pros and cons, and, discuss also about, how the one test brings the next test if it's positive. So this is what I wanted to present to you. I would like to thank you very much for having me today, and I'll be very happy to take questions.
Thank you, Dr. Spilias. That was an excellent presentation, very clear and very thought-provoking. In the new FFR technology that you suggested, it seems as though it's like each artery needs to be done separately. So if you have multiple arteries in a patient, you need to assess, I guess, each one, and that would involve additional, I guess, you don't do them simultaneously, so you pull out, do one, and then do the other, I'm presuming. Correct me if I'm wrong. And then what happens if you come up to, which is about, let's say, a 90% obstruction, and you can't get the catheter through? Then you just go ahead and proceed with revascularization?
Right. So I should during an invasive angiogram, you're correct. So we have to, if we have stenosis in multiple arteries, we have to assess each artery separately. So put the wire in each artery separately. That's the beauty of the CT. The CT is just one test, and we assess all three arteries simultaneously. Now, I would say it's very rare that we cannot cross a lesion with a wire, but it can happen. Then we have different kinds of special equipment to cross the lesion with a wire. We can use microcatheters. We can use special wires like that are a little like stiffer, that are a little like they have a stronger tip that can get through. But there are ways to cross the lesion using special equipment. But I think the beauty of the CT, and we have that now, we're very happy that we have this at the University of Miami, is that we can do all these assessments like non-invasively, and then proceed with the coronary angiogram, the invasive coronary angiogram, only if it's absolutely indicated. So we reduce the risk for the patient, and it's a better utilization of resources, probably.
Thank you very much. We need to move on to our next speaker. Thanks, Nikolaos. That was great. Dr. McBride.
It is my honor to introduce today's second Grand Round speaker, Dr. Sebastian Suarez Zarate. Dr. Suarez Zarate was born and raised in Bogota, Colombia, where he completed his medical education. In 2015, he moved to Boston, where he completed his postdoc and a master's of public health at the Harvard T.H. Chan School of Public Health. He then worked as a global health research scientist at Massachusetts General Hospital in projects aimed to increase access to healthcare in India and Kenya. In 2019, he started his internal medicine residency at Boston University Medical Center, after which he stayed for an additional year as a chief medical resident, and where he focused on the intersection between health disparities and medical education. In 2023, he joined the University of Miami to start his career as an academic hospitalist. It is my distinct pleasure to welcome Dr. Suarez Zarate to the Department of Medicine Grand Rounds to discuss the management of patients with opioid use disorder.
Thank you very much, Dr. McBride, and Happy New Year, everybody. And thank you very much, Dr. Wise and the department for inviting me to present today. So today I'm going to present a case, and I titled the presentation, Breaking the Vicious Cycle, A Role in the Opioid Epidemic. So I have nothing to disclose, and let's get started with the case. So this is a patient I took care of about a few months ago. It's a 28-year-old male with a past medical history of Crohn's disease, spina bifida, with urinary retention, status post of Mertinoff and bladder augmentation, requiring intermittent catheterizations every 4 to 6 hours, a history of C. diff in 2015, and recurrent UTIs, and with the last admission 2 weeks prior to arrival, who presented with abdominal pain, hematuria, and diarrhea. And a little bit more information. The Mertinoff is a procedure that uses bowel to connect the bladder to the abdomen, so patients can urinate through this channel instead of through the urethra. And the bladder augmentation also uses the patient's bowel to enlarge the sides of the bladder. And this is typical procedures for patients with his pathology. So he comes in again with abdominal pain, hematuria, and diarrhea. In the ED, he was hemodynamically stable with a mild tachycardia. He was in acute distress and on exam only notable for tenderness to palpation throughout. His initial CBC and CMP were unremarkable, and his inflammatory markers were also unremarkable. The only abnormality was a lactate at 3.8 that was attributed to his ongoing symptoms. So the initial ED workup included a urinalysis, which was negative, and a CT of the abdomen and pelvis that didn't show any acute abdominal findings. So initially, urology was consulted because of the hematuria, the frequent history of UTIs, and urology did not want to do any interventions, and instead they were concerned that the symptoms could be related to the patient's Crohn's disease, and it could be a Crohn's flare given that the bladder had been reconstructed with bowel. So at this time, they recommended a GI consult. So taking you a little bit back on his history, the patient was diagnosed with Crohn's disease in 2015 after 3 to 4 years of symptoms, and he was started on prednisone and mesalamine. And two years prior to arrival, so 6 years after that. In 2021, he developed acute pancreatitis to the medication. So he was started on adalimumab monotherapy, which he continued for about a year, but then he developed antibodies to the medication and he was stopped on all therapy since then. So by the hospital day 2, GI was consulted and they initially said that they had low concern for Crohn's disease because of the negative inflammatory markers and the normal CT. However, the patient still had the diagnosis and he was due for all of his tests. So they recommended repeating the endoscopy, colonoscopy, MR enterography, as well as the enteric panel and ova and parasite. By hospital day 3, the initial workup was negative, including the stool studies and the cultures, and they were able to perform very quickly all the images, all of which were unremarkable. By hospital day 3, I had heard words like, he's playing you, he's seeking, he is a freaking flyer, and good luck. And these were all words that staff and consultants had used while discussing this patient. And the next day, this is the turning point in this clinical days. I noticed that the symptoms had resolved since admission. The only thing that we had ever given him were opioids. We never gave him anything else. So it was clear at this time that his presentation was consistent with opioid withdrawal. So let me take you a little bit back in time. The patient, since September of 2022, or 2 months after stopping the adalimumab, had been admitted 13 times in the last 12 months with what seemed recurrent UTIs or Crohn's flares because of flank pain, fever, and reported foul-smelling urine. And during these hospital courses, he was always given prolonged antibiotic treatments via PICC lines. And he said things like, I've lived in the hospital for the past year. He told me that he lost 50 pounds. He had to quit his job because he was frequently in the hospital. He had missed important dates like his family's birthdays and Christmas or New Year's, and he had been unable to resume his life. So he was stuck in this vicious cycle that's very common in patients with similar condition as his. He presented to the hospital with abdominal pain, diarrhea, nausea, vomiting, and anxiety. He was admitted, given IV antibiotics and IV opioids, and his symptoms improved. But then he was discharged on PO opioids because he was still in pain. And as soon as his prescription ended, his symptoms returned within 3 to 5 days after the hospital, and he had to be readmitted all over again. This is not uncommon. In fact, in 2021, it was reported that the source of prescription opioid misuse was most commonly by healthcare providers. So only 7.9% of opioids, prescription opioids, were bought from a dealer or a stranger. That's almost close to nothing. 44.9% were given by, bought from, or took from a friend or relative who already had a prescription, and 42.5% were prescribed by a healthcare provider. That means that 87.4% approximately of these, the source of these prescription opioids were from an actual prescription from a physician. And this is very important to understand because of how opioid use disorder works. And if there's one slide that I want you to remember from all this presentation, it's this one, and it's the natural history of opioid use disorder. So not necessarily for our patient, but when patients are starting to take opioids, they take because they get that euphoric sensation, that high, as we call it. But the longer they take opioids, the more the body builds tolerance. So they need to take higher amounts of opioids to produce that familiar dopamine high. But then as they keep taking it, they actually develop physical dependence. So they develop symptoms of withdrawal when they stop using. And at this stage, they are not using to have that euphoric sensation that we all think that patients are doing this for, but instead they are using so they don't feel sick. So they don't feel like they don't want to live anymore because of all their symptoms of withdrawal, including these palpitations, fever, sweating, rhinorrhea, myalgias, nausea, vomiting, diarrhea, abdominal pain, insomnia, anxiety. So it's basically to bring their dopamine levels back to normal. And it's so they can have a normal sensation of life. And so once they have this dependence, opioid use is no longer pleasurable. It's basically to escape distress. And a way to think about it is think of it of a person who has a seizure disorder, how they would feel if they stopped taking their anti-seizure medication. They would have seizures, so they keep taking every day. It's the same as a person with opioid use disorder. They keep taking the opioids because they want to stop feeling sick. Again, if there's one thing to remember, it's this. When comparing the brains of patients who have addiction versus controls, we could see from studies in the early 2000s that the dopamine receptors are lowered in people with addiction, regardless of the drug, which causes a decreased ability to experience any pleasure. So they're feeling flat, lifeless, depressed, and inability to enjoy those things. So they seek that drug stimulation to activate the reward circuit and bring that dopamine levels back to normal, as I showed you in the previous slide. And this is just a comparison of relapse rates between drug addiction and other chronic illnesses. And we see that the relapse rate is very similar to those with type 1 diabetes, hypertension, asthma, and any other chronic condition, which implies that opioid use disorder or any substance use disorder should be treated like any other medical condition, where whenever there's recurrence, it should serve as a trigger for renewed intervention. So a person with opioid use disorder is no more addicted than a person with type 1 diabetes is addicted to insulin. So we should be treating them the same way. And that brings me to the definition of what addiction actually is. It is a chronic, relapsing brain disease that causes chronic changes to the structure and the function of the brain, leading to harmful behaviors and consequences. Again, it's a chronic, relapsing brain disease. And it's not the same as physical dependency or withdrawal. It also needs to meet certain criteria that's been proposed by the DSM-5 criteria, but it's basically based on the 4 C's, loss of control, compulsive use, continued use despite harm, and cravings. So if we're thinking of it as a chronic brain disease, we can also compare it to heart disease. And thank you, Dr. Spilias, for that wonderful talk on coronary artery disease, and it's perfectly tied with this one. So both these diseases disrupt the normal healthy function of the organ. They both cause serious harmful consequences. They're both preventable and treatable. They last a lifetime, and if untreated, they can cause disability and or premature death. That brings me to my first learning objective, which is to describe opioid use disorder as a chronic brain disease and a consequence of physical dependence. So why is all this important? In 2021, it was reported that more than 106,000 people died from drug overdose, of which 75% were attributed to an opioid. And this is one of the most common causes of early death among young and healthy adults otherwise. So I want to put this slide back up, and I want you to look at these words and let them sink in. I'm not sure if these are the same words that we would use for patients who are coming in with DKA or HHS or any other recurrences of our chronic diseases. Yet these are words that we tend to use more in patients who have some sort of addiction. And we in medicine have been not really good with some of our patients and populations, and we have been perpetuators of stigma. We used to call lunatics patients with mental illness, or people with Mongoloid syndrome instead of Down syndrome. Or we used to call people with AIDS as having gay-related immune deficiency. And this has always been based on a discourse dominated by moral judgments that perpetuate stigma and discrimination by linking people to undesirable characteristics. So it's no different with opioid use disorder. By using words like abuser or junkie, we kind of think of something like this, where individuals are morally at fault for their disease. But we've already established that this is a chronic disease of the brain. And saying that a patient needs the willpower to quit implies that we should expect then the same of our patients with type 1 diabetes, that they should have the willpower not to use insulin. And that's simply not the case. And abuse is also, it also has a lot of emotions connected to it. It's close to words like homicide and rape, so it associates patients with crime. Instead, we should be using language that is more medical and evidence-based, such as opioid use disorder. And this is something that we call words matter by using person first language, which recognizes that people are, first of all, people. We need to humanize how we treat patients with addiction and opioid use disorder. There's many studies and across multiple journals that talk about this, including in JAMA and the American Journal of Medicine, and more recent studies where they use simulations by just using patient prompts, comparing cases with the word abuser versus use disorder. And one study showed that addiction specialists were more likely to assign blame and suggest punitive actions when they read the word abuser rather than use disorder. And mental health providers were less likely to believe that these patients deserve treatment when they were shown the prompt with the word abuser instead of use disorder. So even among the well-trained clinicians who treat these patients all the time, exposure to the word abuse or abuser can create an implicit and cognitive bias. And all of this also promotes shorter visits, less empathy and less engagement, less interest in prescribing medications for opioid use disorder, suboptimal care by not providing evidence-based treatments, and patients with diminished feelings of empowerment. And we can all say like, okay, but these are words. Why do they even matter? These are just simulations. There was a recent study in 2023 published in the Journal of Hospital Medicine, the first study in real life world that showed that compared to the word abuse, writing use disorder in the discharge summary was associated with increased odds of documented plan for opioid use treatment and follow-up opioid use disorder care. It doesn't mean causation, but it simply implies that clinicians using guideline concordant language were more likely to consider treatment and interventions for this condition because they were more likely aware of this chronic disease model of addiction and engaging in evidence-based practices. And I'm sure many studies are more to come. In our patient's chart, when digging through Care Everywhere, because he was new to our system, there were words like polysubstance abuse, substance abuse, and drug abuse all over. And we can see how this can have an impact in our patient. So we should actually use preferred language. So instead of using the words addict, user, junkie, abuser, drug seeker, or drug habit, we can just refer to people or patients with substance use disorder, opioid use disorder, with addiction, or people who inject drugs. Instead of saying opioid use or opioid dependence, the same thing. Instead of saying they have clean or dirty urine, we can just say negative or positive urine drug test. Instead of saying they're clean, they're a former addict, they're sober, we can say they're in remission or in recovery. And we should stop saying that this is a choice, a lifestyle, a moral failing, or a lack of willpower, because we now know it's a chronic condition that affects multiple brain systems. And please, it's not a narcotic. Narcotic is used in the legal context, and these are opioids that they're taking. Which brings me to my second learning objective, which was to examine the impact of stigma and non-preferred language in the care of persons with opioid use disorder. So back to our patient. By hospital day 4, the patient was with his son, his partner, his mother, and his sister at the bedside, and I counseled them on what was going on. They were actually very understanding and receptive of the diagnosis, and were actually shocked that they had never heard that this was a possibility of what could be happening. He knew that in his chart it said that he had polysubstance abuse, and he never thought that these symptoms could be caused by that it was opioid withdrawal. In fact, he was actually hopeful that it was unrelated to his Crohn's disease because he'd been with this diagnosis for so long that he always thought it was his GI pathology that was causing the symptoms. And when I talked to him about the possibility of treatment, he was extremely interested in treatment. Him and his family said, "This is the first time we've had hope in the last year." Nora Volkov, which is the director of the National Institute on Drug Abuse, a name that should be changed, as we talked about, said that drug addiction is a brain disease that can be treated, and there's treatment, there's evidence-based treatments. Here is a picture of the changes in a person who is healthy, then a person with addiction, and somebody who's been on recovery for more than a year. And we can see that the function and the dopamine receptors are very similar, almost the same between the patient who's in recovery and a healthy person. So this is reversible. This is something that we can help our patients with. And there are medications for opioid use disorder that have shown to be useful to treat and prevent complications from this condition, including methadone, that's a full agonist, buprenorphine, that's a partial agonist, or naltrexone, that's an antagonist. And in 2018, there was a study that showed that in the 12 months after a non-fatal overdose of those enrolled in one of these treatments, compare of those who were not enrolled in one of these treatments, showed that there was a decrease in opioid-related mortality, all-cause mortality, with methadone and buprenorphine. Naltrexone, unfortunately, did not show any significant difference. What does this mean to us? It means that the number needed to treat for methadone is 42 and for buprenorphine is 53. So for every patient for every 42 patients we treat with methadone and for every 53 patients we treat with buprenorphine, we are saving one life. And let me show you that aspirin and statin for cardiovascular mortality secondary prevention, the number needed to treat are 333 and 83 respectively. When I learned this, I was mind blown. I could not believe that medications that we prescribe on a daily basis and that we religiously prescribe are not as effective in decreasing mortality as these medications for opioid use disorder. Sadly, in 2021, only 1 in 5 patients with opioid use disorder received treatment. Only 22% of patients for a treatment that is more effective than any other medications that we are using on a day-to-day basis on our practice. And that's not only it. It's not only about mortality. There's other evidence-based benefits of medications for opioid use disorder, specifically methadone and buprenorphine. They decrease opioid use, cravings, and withdrawals. They normalize brain changes, as we've seen. They also decrease HIV and hepatitis seroconversion because patients are no longer injecting drugs. They decrease criminal activity. They increase employment, both of these because patients are re-engaging in society and in their day-to-day life. And they improve birth outcomes. So I want to challenge you to tell me if there are any other medications that you use that can do the same as these medications and as effectively. I haven't found one yet. And going back to this slide, it's important to note that when patients get medications for opioid use disorder and when they're in recovery, they get their life back because all their receptors and their dopamine pathways, they are normalized to the point that they can re-engage with everything that they used to do. They're no longer feeling sick every day that they need to continue using. On January 2023, it was announced that the X waiver was eliminated. So the X waiver was a requirement, a training, extra training that all physicians and clinicians had to undergo to prescribe buprenorphine. So now, since that has been eliminated, everyone with an active DEA license can prescribe buprenorphine without any additional training. Some states still require this for licensing, but any one of us here with a DEA license can prescribe. So I hope that I have convinced you that all patients with opioid use disorder should be offered medications for this condition at every and all healthcare encounters. And I will plug here, there's a new protocol that we are implementing at UMH with the Division of Hospital Medicine, Psychiatry, and Pharmacy to prescribe buprenorphine for hospitalized patients with opioid use disorder. And this is going to launch in the next few days. I'm very happy, and thank you, Dr. Joshua Laban, who has been leading this, this protocol. And so for our treatment plan for this patient, by hospital day 5, we had already stopped opioids and the patient started to develop opioid withdrawal. We prescribed buprenorphine and I helped schedule an appointment in the Jackson Matt Clinic and gave him a list of resources provided by the psychiatry team. And then we discharged the patient home. To me, this was a success story because 2 months later, I called the patient. I was very curious and he told me that he had been taking his buprenorphine daily. He hadn't had any new symptoms since he was discharged. He had already gained 10 pounds. He was going to the gym every day, and he had even gotten his job back. I was shocked to hear all of this. And he also said he hadn't been to the hospital in 2 months, which has been the longest he'd been out of the hospital in 1.5 years. He told me, I have my life back. I was able to be home for my son's birthday. It was a very, very pleasant conversation just to be able to do something so simple that could have such a big impact in someone's life. And I hope all of you will be able to do this one day. So let's go back to this vicious cycle that we talked about. I hope that now we'll be able to recognize when patients are having symptoms of either opioid withdrawal or opioid use disorder, maybe a little bit more today than yesterday. And instead of discharging patients on opioids, we should actually stop opioids altogether and start prescriptions for medications for opioid use disorder, including buprenorphine. This will aim to improve symptoms, help them thrive, enhance their well-being, regain employment, and have them re-engage in society. And if there's any help that you all need, our team in the Division of Hospital Medicine and Psychiatry will be more than happy to help. So that concludes with my third learning objective, which is to recognize methadone and buprenorphine as life-saving medications that should be offered to all patients with opioid use disorder. And my references, and thank you very much.
Thank you so much, Dr. Suarez Zarate. That was an excellent presentation, very chock full of lots of good, important learning points. We have just a few minutes for a question or two, and maybe I can begin by asking what effect, if any, has the new requirements on opioid prescribing of physicians had in decreasing the incidence of opioid use disorder? All of us, when we had to have our license renewed, had to go through multiple hours of training, and there are actually limitations on prescriptions for the number of days that opioids can be prescribed unless you're treating chronic pain, which I guess is the way to get around it. Is there any data to show that any of those regulations have impacted the incidence of the opioid use disorder?
No, it's interesting you asked. Not that I know of. In fact, since the regulations have been lifted, there have been really few studies showing that there has been an uptake on the prescriptions. And I think it's partly based on the fact that physicians have been told not to do it. So the problem right now is that there's not enough training, and the training that we're doing, which are these required courses, seem like they're not enough because there's not enough mentorship between like the trainees and the senior physicians who typically, are teaching or showing other providers how to do it. So I don't think still there's any data that these, required trainings are working, but if others have know about this, I would like to know.
Thank you very much. I think both our speakers today showed off the best of hospital medicine and cardiology, and we're grateful for your presentations today. I want to welcome everybody back after the New Year celebration. Remind you to go into the chat for the link for the MOC and CME credits, and wish everybody a wonderful, terrific day. Thank you all for coming.